I went to the university, I went to vet school and I wanted to be a feline practitioner, and that's what I've always wanted to do. And I did an internship and I went into feline practice, and I loved feline practice, but I just started to struggle with the things we didn't know for cats.
Sorry for saying sorry. Media presents the Purr Podcast, the best podcast for feline medicine and surgery with tips, tricks, and updates for the entire veterinary healthcare team. If you're dying to know more about cats, keep on listening. Here are your hosts, Dr. Susan Little, famous cat vet and textbook author, and Dr. Jolle Kirpenstein, talented surgeon and social media geek.
This podcast is supported by an educational grant from Kindred Bio. Hi, this is Dr. Susan Little.
And Dr. Jolle Kirpenstein, and this is the Purr Podcast.
You know, I'm doing really good because I think the last 3 interviews we've taped,
Yes.
I've actually started. So I'm looking at our guest, who you'll hear in a minute. So
Who's
typically what
laughing?
happens is we both stare at each other because nobody knows who to start, right? So one time, actually, our guest started because
Yes.
we were like stuck in like, who? And then so our special guest.
That was
starts.
Eric Garcia.
That was
He
Eric,
took
that's
over,
right.
And he was just
Eric just took over and
amazing.
ran the podcast after that. So, yes.
So,
Anyway,
so where are we, Dr. Susan?
we are in lovely San Francisco,
Mhm.
which, if you're Canadian and it is a cold time of year, is a good place to be.
You know,
Yes.
it's like
There's a lot of Canadians at this meeting.
there's a lot of foreign people in general.
In
at this
general.
meeting, so
Are we foreign? Canadians? Are we foreign?
I think so.
Okay.
I think
Depends
so.
on your perspective.
Yeah, no, not for me because I'm foreign too. I used to be an extraterrestrial alien, I said, in the US, but now I think I have a green card, so I'm now a not immigrant, whatever
That's
alien.
such
it
a
is.
funny term that you're an alien.
Yeah.
Yeah, Canadians don't say that.
No.
You know, we're friendlier. We don't call you an
You
alien.
know,
Yeah.
feel a little green,
Mhm.
have some skills.
So the only American with us is you.
Yes.
Yes.
So
Yeah.
welcome.
Yeah.
Thank you.
Yeah.
Yeah,
And would you like to introduce yourself?
Yes, I'm Dr. Jessica Quimby, associate professor at The Ohio State University.
The Ohio State.
The.
Yes,
As we
I
say.
know. I get that all the
Really
time.
like
It's
that.
like stuck in everybody's
Yes.
vocabulary now, right? You have to go,
Yes.
the Ohio State.
Yes.
I don't know, but that started
So,
a long time ago.
and why is that? Do you know?
I have no idea because I'm new to
Oh.
the
So
university.
when did you start there?
So I've been there for about 2.5 years now.
Time flies.
I know,
Oh,
I
look at
know.
that.
I feel like you just got there.
I
I bet you
know.
do too.
I know,
Yes, I
I
kind
remember
of do.
this.
Right.
Oh, wow.
Time does fly.
Mhm.
Yeah.
So we still don't know what the D is for the. We'll probably know.
There was a
Our
time
quest will
when
keep on
I know
going.
people just said Ohio State. And then somehow it got corrected to it's the Ohio State. It's like, okay.
Well, I mean, I don't know if this is true or not, but I've been told that you have to use the when you say university. So you could say Ohio State, but if you said Ohio State University, you have to say the Ohio State University. But I feel like this should have been like in the training documents because I don't actually know if that's true
So
or
is it
not.
gonna be
for the
So-
orientation.
I know. I'm like,
But is it
So-
the Kansas State University?
No.
then?
No.
Nobody does.
No.
It's only
Oh,
Ohio
it's only-
State.
Okay.
I know. So poor Jessica gets there and everybody's going, the Ohio State. I know.
I
It's,
just throw up my hands.
it's just a weird thing in
Yeah.
veterinary medicine, I
Oh,
guess.
that's
Yeah.
awesome.
Yeah.
It's a
Well,
beautiful-
and when I first went there, and the OHIO thing too, like I'm still, I like literally I'd been there for approximately 3 days, and
Yeah.
I went to WVC, and I got in the taxi, and the guy said, "Where are you from?" And I said, "Ohio State," and he goes, "OH," and I just looked at him, and I was like, "Excuse me," and he goes, "Oh, I guess you haven't gotten that far yet."
Because I gather you're supposed to
Like-
go,
I
Iowa.
had no idea. I mean, it's been 3 days, literally, since I started the job. So,
So there's a
Oh,
place
wow.
for a
Right.
good orientation manual.
Mhm.
Yeah.
I know.
how to be a Buckeye.
How to blend in seamlessly. Yes, as you transplant yourself, because you
Right.
were at Colorado
I
State
was. Yep.
for
I was.
a long time, huh?
11 years.
Yeah.
Yep. So
Wow.
my residency and then PhD and then was faculty there for a couple of years,
Yeah.
a few years before I went to Ohio State.
And
Yeah.
tell us a little bit about your background. What
Yeah.
do you do?
Yeah, so I am, well, I mean, before I went to the university, I went to vet school and I wanted to be a feline practitioner, and that's what I've always wanted to do. And I did an internship and I went into feline practice, and I loved feline feline practice, but I just started to struggle with the things we didn't know for cats. And it was just, there were so many questions, and it just seemed like whenever drugs were approved or projects were done, they were very dog focused. And so I just suddenly developed this passion to really learn more for cats specifically. And that's kind of what inspired me to go back and get further training. And I chose internal medicine because it kind of resembles feline geriatric medicine.
Yeah.
Right. So it's, that was really where my passion was. And then, chronic kidney disease is just such a huge, insurmountable problem and so many questions to be answered. So that's why I ended up focusing on that for my PhD.
Yeah. So that's kind of taken over your
your
life,
yes,
hasn't it?
Yeah. So
yeah.
And luckily many other people are interested in kidney disease now too. So that's
it's a whole little
really
like subculture.
It is, right? So it's become
a good thing.
A hot thing. So.
And are you still able to do mainly cats then?
Yeah, so part of the year, I do research and I teach, and I'm on clinics as an internal medicine specialist. So there are times when I oversee the clinical service as faculty, and I'm teaching residents and interns and the students. But then also, and during that time, we see cats and dogs. But for the purposes of my specialty, feline nephrology, if you will, and then for the clinical trials that we usually have for kidney disease, then that's when I get my cat only fix, because those people are coming in then to see me and talk about their kidney disease and participate in trials. And so I gather them. And then a lot of the staff and the faculty and the students come to me as well with their kitties.
You're the cat lady.
So yes. So, and there's a couple of us, so it's not just me, but then I can, I enjoy my feline.
You get your cat fix.
Yes, right.
I love that.
What kind of stuff do you have going on?
So, well, we have a number of projects going on at the moment. We have been obviously always looking at mirtazapine. We just finished up some studies there. We've been looking at gabapentin in chronic kidney disease. So, it's just been such a transformational thing to be using the gabapentin to really help cats get into the clinic and be less stressed. And we became a little bit concerned there with some anecdotal feedback that we were getting, because it's 100% renally excreted. So
wow.
Yeah, 100%. So if your kidneys are not working well, you may not be excreting your gabapentin. Yeah. So
not many drugs are like 100%.
No, it is.
That's
it's pretty beautiful. So on the human side, they dose reduce quite a bit for kidney disease, and we thought, oh goodness. I wonder. We probably, and when I was asking a lot of the feline practitioners that were starting to use it, they said, oh yeah, we've definitely noticed that. I experienced it in my own cat. So we're in the midst right now of a nice study looking at what the pharmacokinetics of that sedation dose looks like in normal cats, and then how we compare that to a reduced dose in chronic kidney disease cats.
Because we reduce the dose of other renally excreted drugs that aren't even excreted 100%.
Right.
And we do dose reductions, right?
Yeah.
So,
and this has implications for even not just the sedation dose, but also using it for,
analgesia,
long-term, and my osteoarthritis kitties.
Yeah.
And we're seeing these kitties that go home and they are getting, a dose that basically is the same as my sedation dose for their chronic arthritis, and they're getting too sedate. And then the owners are scared to use the drug. So we definitely need to figure out what to do with that. And the preliminary results so far are showing exactly what we suspected. So
do you think, is it a matter of dose reduction or extending frequency, or both? Because that's always the
both.
thing.
So that's actually what's curious about it, is we are finding that the half-life is longer, and hopefully we'll be presenting that at ACVM this year.
Nice.
But the other thing is that we do also have to dose reduce, because they're still more sedate, and so that part of the pharmacodynamic picture is a little less clear. We don't quite understand why that's happening. So my own kitty with chronic kidney disease, she needed a 75% dose reduction.
Whoa. Wow.
Yeah, otherwise she just,
You're microdosing now.
She wouldn't sleep for days,
I've definitely seen that, the little, especially like
2-3 kg.
Those guys,
yes,
like the low body condition, low muscle condition, those guys, and it'll just knock them out. Even at half the dose.
I can imagine the PK/PD data change completely if your kidneys are not working exactly. So it's not only the amount that you give, because that normally says the peak that you get, but also the excretion and
volume of distribution. Who knows?
Your
I mean,
area in the curve is going to completely change.
It will. It will. So that's the thing, is I'm wondering, is even in that short period of time that the area under the curve is really jumping up there for those cats.
And so are you? Is that the data that you're looking at? Are you do PK/PD data analysis? Yeah.
Pharmacokinetic, pharmacodynamic.
I know.
Yeah.
So we actually have a WIN Feline Foundation funded study right now, and we started actually just with some looking at the PK, so that we would be better informed about what we wanted to do with our pharmacodynamic study. So right now we're looking at just blood levels, and that's going to help us choose then how to do a placebo-controlled study in the chronic kidney disease kitties. So I foresee multiple studies to come, and we are definitely concerned that maybe there might also be an effect on blood pressure, especially if they get too much. So in normal cats, it hasn't really been shown to affect blood pressure. But if you're a chronic kidney disease cat and you've gotten too much, we've seen some cats who, they're a bit zonked, if you will, and then their blood pressure is
low. Drops their blood pressure.
90 to 100. And so,
oh lordy, it really drops their blood pressure.
Yes. So, and of course, to some extent that could be an anxiolytic effect, but not at 90 to 100. That's I'm too sedate. And there is some evidence in the literature that it could have a direct blood pressure effect. So we really need to find that information out in order to use it correctly and safely for those patients, because it's such an asset. I mean, it's been so helpful, And hats off to the WIN Feline Foundation. We love WIN.
Yay, WIN. We've talked to many people like yourself who are researchers who have WIN-funded projects. Yes. It's been instrumental. Hats off to the WIN Feline Foundation.
So let's talk about the amazing M drug for a second.
Yeah, so you mentioned mirtazapine.
Really
that's another drug we have to dose differently with kidney patients, right?
Yep. So and I think what it's coming about that appears at this point in time, though, is it might depend on what kind of mirtazapine that we're giving, though.
What do you mean, what kind?
So, I mean, a lot of our original studies were done with oral mirtazapine.
Yep.
And they definitely, based on the studies that we've done and the studies that now have been done with the FDA-approved transdermal form, when you give oral mirtazapine, your blood level spikes a lot higher pretty immediately after you give that oral dose.
So it's highly bioavailable by oral route?
Yep, exactly. Okay. But as you would expect for the drug, but that's not necessarily a good thing if it goes so high that you're getting those side effects. So some of our previous studies with the oral form have shown that that dose is really associated with the side effects. So the higher the dosing, the more the meow, meow, meow. And then we get this like unwanted hyperexcitability and kind of the crazy behaviors.
So serotonin syndrome.
Yeah, and that we don't want. Like you're not going to eat if you're running around screaming.
Crazy.
Yeah, being crazy and talking to your people and you can't even sit down.
And they can get quite toxic too. Not coming by accidental overdoses usually, right?
Yep. So when we had looked at accidental overdoses in the cats, and this was one of the things that drove us to looking at more specific dosing, because in that study we saw that the most common toxicities reported to the ASPCA were actually accidental administration of a full 15 milligram tablet or the 3.75 milligram dose and a 7.5 milligram dose. Those were getting a lot of hits from toxicity, but that's like 1 to 2 mgs per kg.
It's huge.
That's huge, or even more than that. And normally we're giving really small doses, like 2 milligrams, 1.88, the traditional dose.
And
the eighth of the 15 milligram.
Audience, what are the common signs of too high dose?
Too high dose. So, one of the things that we reported in that paper would be just, extreme vocalization. They can get tachypnic, tachycardic. They're really
kind of frantic
behavior, speedy, if you will. And just on a more subtle level, though, we don't want them just pacing and restless and meowing. Like that's too much. So even in the individual patient, regardless of the dose we're giving, we dose reduce if we're seeing that. So, when something is approved at a certain dose, for me as a veterinarian, I still might need to look at my individual patient and say, I might need to alter this based on what's happening in this individual patient. And we see that more with the oral form because it does basically have more drug exposure, that area under the curve that you mentioned. They're getting more of that because those drug concentrations are higher. And with the transdermal form that we studied and also the FDA approved product, it's not necessarily going up that high, and for that reason we actually feel like we're seeing less side effects with the transdermals, which is actually a good thing.
And it would be harder to overdose. It would be
accidentally,
right?
Yeah, it would be harder to overdose.
So it's a safety issue.
Yeah. And so, we're fortunate in this country that we have this product now. We don't have to worry about mistakes in compounding,
exactly,
that type of thing, but our friends and cats in other countries may not have that. And so for that reason, we actually did look at compounded transdermal mirtazapine. That's
not the FDA approved form, but another
so
transdermal form.
If you were somewhere else, we lecture internationally, and people in Korea say, we want this. What do we do? You know, can we have a transdermal? And so hopefully our studies looking at that would inform what to do. But the interesting thing that we've noticed is when we use that compounded formula, which can be quite inaccurate, it still helps, but the cats did really have side effects when we gave it once a day. Whereas now some sub-study has been done with the Mirtaz, and we don't really seem to see that for the most part in the studies that have been done when those cats get it daily. So they seem like they're absorbing it better, and it's being processed more appropriately. Whereas with the compounded medication, it's hard to grind up that tablet and put it in the gel, and they have excipient on their ear. And
might not absorb well.
Might not absorb.
Can be erratic probably from day to day.
Yeah, so there's a big difference there.
And every pharmacy that makes it might make it different.
Oh yeah, we tested some gel levels, and they were all over the place for the compounded
which we
products.
See in all compounded products.
I know, and it points out, because these companies normally put quite a lot of research into the product that they
that gets licensed.
And obviously when the FDA licenses, they have to jump through many hoops to get this product to be as it is, and that for compounding efforts, that's not happening.
No.
And so there's a huge difference.
Yeah.
Let's just circle back a minute and a couple of more questions on the getting back to oral forms and especially accidental overdoses. So what's sort of the worst case scenario? Have you seen seizures? Have you seen, or sort of how bad can that get?
I mean, I have not personally seen any really bad scenarios. Okay. Most of the time when it's happened to me in hospital, like heaven forbid a staff member accidentally gives, we've actually caught it pretty quickly and, induced.
And then what do you do?
Yeah, what do you do?
We usually, if we can get them to vomit it up immediately, that's good. Great. But of course, that's suboptimal in my sick patient.
No, you're trying not to vomit.
Yep.
Yes.
But then also ciprofloxacin would be the antidote. So
isn't that interesting?
It is, right?
It's such a strange thing that one appetite stimulating drug is the antidote for another.
Yeah. So, and that's something we definitely have to make sure that owners are aware of.
And vets.
Don't
double up.
No, it's 2 is not better.
Yes.
Not in this case.
Right. So definitely you could be, interfering there. And so, I think we did have one case where it was discovered too late that the cat had gotten the overdose, and we did give ciprofloxacin at regular intervals.
And did it help?
It did help. Yeah. So a little tremory. The worst I've ever seen is just tremory and really discombobulated and meowing.
That's the worst I've seen too.
Like vomiting.
So not like life-threatening, but nonetheless dramatic, possibly dramatic and uncomfortable.
It's hard because that, it's like, well, that patient is already sick. So, in the ASPCA study that we did, there were some cats that died, but I have no idea. Like those cats were already sick, and only like there was just not hardly any. So like maybe somebody.
So did they die of their disease?
So there's no evidence that they actually died from the mirtazapine overdose. And those cases, some of them, there wasn't even enough information to say anything about. It's like, well, you're already quite sick. We've no idea. Yeah. So we have not seen that happen, but it's important to know that ciprofloxacin is the antidote.
Yeah. So there's lots of times we might want to use a drug like mirtazapine. Why would we use a drug like mirtazapine, let's say, over cyproheptadine? So there's two drugs.
Yeah.
How would you prioritize those?
Well, I mean, I guess I feel lucky, if you will, to have, I guess, been in feline medicine during the time when we actually didn't have mirtazapine, because cyproheptadine just was never that great. It just, it'd be like, well, yes, for some cats it works, but it often caused sedation.
And they didn't eat, they ate more, but not enough
they
more.
They didn't eat that much, and so it was just like, well, this is what we have, and other things.
But it was better than like Valium or diazepam.
Well, yeah, certainly orally.
Before we moved to cyproheptadine, it was the benzodiazepines.
Right. And then of course you've got that risk of hepatotoxicity with oral Valium. We don't want to do that.
Don't want to do that. And there's a lot of sedation with those drugs.
Yep. And so, it was just like, well, this is not impressive. And so about the time that I was going back to the university from feline practice, we've been using it all the time in these patients. And we saw this information about the new drug that was coming out, of course, on VIN. This is where, right? So we see this information on VIN.
That's where we see things.
And we're like, oh, this is really intriguing. So we start using it. But then at that time, the recommendation was 3.75 milligrams every 3 days.
It was. I remember that. I used to do that.
Yeah. And we thought, oh, there's something wrong here. It's too much. The dose is too high. And it doesn't last for 3 days. There's no way. And that was just a postulated guess based on...
It's what you do when you don't know.
Right. So that's what motivated us to do these original studies looking at the oral form and the pharmacodynamics and the pharmacokinetics. And what we found was very surprising. It was not... I mean, that's why we need these studies for cats.
Yes. So we need if you're using an oral form...
Yeah.
I don't think there's a licensed oral form anywhere, right? So
there's a 2 milligram tablet in Europe and the UK, I believe. Yes, but I don't know if it's a license. I actually don't know enough about that, but they tell me there's a 2 milligram
They
tablet.
just may have a different tablet size.
Yes.
Anyway.
And ladies, I already warned you, this discussion goes on, but we're already at 25 minutes. I know.
We barely touched the subject of getting cats to eat.
I know. But
we'll have to continue. I'm not done.
No, but we have another session coming up in 2 weeks.
Thank goodness.
Wow. Okay. So we need to talk about why. Then.
Yes, exactly.
Why?
So why.
What to monitor and why we need these medications.
Okay.
Exactly. So, but I really appreciate it. I mean, it's so... The discussion is so vibrant. It's wonderful. I love that.
Because we're excited about the topic.
I might get a little excited about it.
But I think it's interesting to see, we used to have one drug that was quite awful. Then we got another drug that was
a little
just
better.
Kind of better, but it was not really. And now suddenly we have something that everybody's really excited about. That's cool.
But it took the research to figure it out. So.
Right.
That's exactly it. So thank you so much.
Of course.
And
we'll be back.
Yeah.
Okay. Yeah. Stay tuned.
All right.
Dr. Susan Little is a feline medicine specialist with 2 cat-only hospitals in Ottawa, Canada. She is best known as an international speaker and as the author and editor of 2 textbooks, The Cat, Clinical Medicine and Management, and August, Consultations in Feline Internal Medicine. Along with 3 cats, she also admits to owning 2 dogs, and you can follow her on social media with the handle @CatVetSusan. Dr. Jolle Kirpenstein is a diplomate of the American and European College of Veterinary Surgeons and a big cat fan. His specialties range from surgical oncology and reconstruction to minimally invasive surgery. He is the author of 2 textbooks on basic and reconstructive surgery. Did you know he was allergic to cats? Jolle works currently at Hill's Pet Nutrition. You can follow him on social media with the handle @GVETSX. The opinions of this podcast are those by Dr. Susan Little and Dr. Jolle Kirpenstein. Veterinary medicine is a complex profession, and often there are multiple diagnostic and therapeutic options for different disease processes. If you're a pet owner with questions, please go to your local veterinarian. If you're a veterinary professional, ask your questions on our Instagram page @Purr Podcast.